The PI treatment regimens in general have been very important. We now have actually 7 different classes of drugs approved for myeloma, and those include steroids, conventional chemos, IMiDs, proteasome inhibitors, HDAC inhibitors, monoclonal antibodies, and XPO1 inhibitors. So a key backbone is the PI. And some of these classes of drugs weren't approved until the last 4 to 5 years. So what is responsible for the improvement of median overall survival in myeloma patients prior to this last few years is really the approval of immunomodulatory drugs and proteasome inhibitors. And so luckily we have 3 major proteasome inhibitors that are already FDA approved. First came on the market was bortezomib, followed by carfilzomib, followed by ixazomib. And they each have their own flavors or features. Bortezomib, been around for a while, can be given subcutaneously. Initially was approved on a twice-weekly schedule, but now many combination studies are using it weekly. Carfilzomib does not have the neuropathy that bortezomib is associated with. It must be given intravenously, typically over 30 minutes, particularly for the higher doses. And there's many doses and schedules which can add a little bit to the complexity, but that's the second PI. And the third PI is the ixazomib, and this has going for the oral convenience that allows it to be given to progression without the fatigue that patients may experience in terms of coming to hospitals for the injections or infusions. In general, the choice of a particular PI regimen is dependent on, I think, patient factors, disease factors, and treatment factors. And so we kind of covered some of the issues with the treatment factors, but the patient and disease factors are also important. So patient factors could include age and frailty, renal function, cardiac history, neuropathy, insurance status, the ability to cover oral medications versus injectables. So there's a lot of patient factors that they would be go into making this decision. And of course, there's disease factors. For example, the international stage, the disease burden along those lines, the amount of symptoms in terms of hypercalcemia, renal insufficiency, anemia, bone disease, and also high risk, in particular 17p deletion, translocation 414. And I would say just one point to that 414, when we look at high-risk disease, a lot of regimens that have been approved improve the outcomes of high-risk patients, but none have really overcome. And I think the closest we come to overcoming high risk, which means that high-risk patients are doing almost as well as standard risk, is with the PIs and translocation 414. So I think that is a nice niche for these PIs. And one consideration is really also it's important in clinical trials that we always treat to progression, but we've known from the real-world data that often patients aren't being treated to progression. And so it's important to think about making the regimens convenient. So for example, weekly schedules or oral schedules to allow that treatment to progression. The indications and coverages for the PI, right now we have bortezomib essentially can be used throughout the disease continuum, starting with newly diagnosed. Carfilzomib has its initial approvals based on the KRD study, which was KRD versus RD, and that was for 1 to 3 lines of prior therapy. Also the ARROW study for the similar population, which is weekly carfilzomib, and initially it was approved very early on as a phase 2 in the advanced setting. It is, however, also listed in the NCCN as a possible option for newly diagnosed patients and might be, as we discussed earlier, preferable for perhaps those young patients who have high-risk disease or who have concerns about neuropathy, perhaps a diabetic patient but no cardiac history. Those might be patients to consider for newly diagnosed. And ixazomib, which is the only oral PI, has its indication based on the tourmaline study, which was IRD, ixazomib Lendex versus Lendex, for 1 to 3 lines of prior therapy. And that showed also improvement in PFS. So that's a good option for patients who live perhaps a long distance from the infusion centers and need an all-oral regimen. And so that's a good option for those patients.